what is this bone right here?
Navicular.
Navicular, okay? What do we know that comes down? We talked a lot about today. Comes down and attaches, has some attachment in navicular, a muscle. What muscle? Posterior tibialis, right? That's really important and functional, right? Okay, so what bone comes just, let's go to this side. So calcaneus, what is this?
The first metatarsal.
It's metatarsal, right? This is left foot, okay? It's left foot. All right, what is between there? Okay, so then we get these three little bones right here. What's this one?
Lateral cuneiform.
Good.
Medial cuneiform. Well, no. Intermediate.
Intermediate or middle. Okay, you might see it either way. But what is this one?
Lateral. I'm medial.
Medial cuneiform. Good. Okay. So I'm not sure how many of these mobilizations that we'll do today, but you're going to want to have an understanding of where these bones are right here. Okay. Do you see? And this just for palpation purposes. Can you see where they come in? Right. So here's the first. What is this?
First metatarsal.
First metatarsal comes into the
Medial cuneiform.
medial cuneiform, right? So I can mobilize there. The second metatarsal comes into what?
Intermediate / medial.
Okay. Third metatarsal comes into?
Lateral.
And then the fourth and the fifth articulate with?
Cuboid.
Good. Okay.
Look, that was so easy.
Yeah.
So
See,
now
you guys know this?
That's crazy.
And those are
Mm-hmm.
concave on convex.
Concave on convex, yes.
So easy.
Okay. So, it's fairly simple. We've got a plantar glide, we've got a dorsal glide. Plantar glide, dorsal glide, okay? Like I said, I'm not sure how much we're going to get into all the specifics, but you can figure that out.
So it's plantar glide forward flexion for the metatarsals on. We're just mobilizing that because it's concave on convex. That's plantar glide for a flexion moment.
That would make sense.
Okay.
So if it's concave on convex, it's going to go same direction. Swing, the roll, the glide, same direction. Okay, good. All right. So how about the toes? So big toe, super functional, super important. I pay a lot of attention to it in the clinic. Okay. Plantar fasciitis, some of that stuff we talked about today, I pay a lot of attention. A lot of your people with gait dysfunction, you're going to see they're lacking first toe mobility. How much first toe mobility? How much first toe extension should we expect passively? Anybody know?
70 to 80.
Okay, depends on the resource, but you're gonna want to see at least 60, right? Somebody who's sprinting and doing something even more significant, you're gonna want to see more, right? Okay, so what is this joint? Is this concave on convex? Convex on concave? What do we got?
Concave on convex.
Okay, so if we wanted to, so what motion is what glide is necessary for first toe extension at the first MTP joint?
Plantar. Oh no,
Dorsal glide. Okay, right? A dorsal glide. Okay, so that's an important motion. So let's say that you in the practical were given perform a motion to improve first toe extension at the MTP joint. Okay, you just told me you would do a dorsal glide, and our question might be, what are you moving on what? Who can tell me that?
First.
Phalanx on the
Prostophalanx on the first
metatarsal.
Tarsal. Good. Okay. Remember that. You're going to get those follow-up questions, right? If we ask you, let's just go back to the thumb. Let's go back to the thumb, right? So if we're doing CMC, what is this?
Flexion.
Flexion. Okay. If I say perform an accessory motion necessary for CMC flexion, what would you do? Ulnar glide. Okay. Ulnar glide, medial glide, both would be appropriate. Okay. Then I would say, okay, what are you moving on what? Metacarpal.
On the trapezius.
Good. Okay. Remember that. Don't forget that. Those will come back. Okay. But so be prepared for that. So as you're preparing this week, think, what am I moving on what? Okay. You can relate it back to the concave convex rule. Your knowledge of anatomy really does set you free on a lot of things. Okay. I saw that throughout those presentations today. Even with your special test today, if you know where the calcaneofibular ligament is, if you know where the anterior talofibular ligament is, then you will understand why if you move the foot in that motion, why it would stress it. Looking at the ankle, okay, you've already referenced in presentations today anterior drawer, tailor tilt, okay, in inversion, tailor tilt and eversion. So again, remember your anatomy, right? So if I'm going to do a tailor tilt, I've got the person here, I'm into inversion. What ligament with the foot in neutral dorsiflexion? What ligament am I most likely to stress, just based on your knowledge of anatomy? Calcaneofibular. Now, if I take that foot into a little bit more plantar flexion, what am I going to put a little bit more tension through? Okay, say it again.
The anterior.
ATFL, anterior talofibular ligament, right? So you'll see that with a few different tests that there you can bias it and maybe glean a little bit more with foot in plantar flexion versus foot in neutral or even full dorsiflexion. Okay, so just a couple nuggets to pick up on as you're doing these special tests today.
So we're doing the compression squeeze test. So long sit, please. Squeezing. And then just noting if there's any pain with that.
So, likely if it is positive for a fracture, it will likely be positive at the fracture site. This is not all inclusive. If the patient does have a deformity, this should not be performed. More likely refer out for x-ray, when there is an obvious deformity. What else do we want to point out with this test? What would likely, if this test is positive for fracture, what would likely be the patient's description of pain? Do y'all remember those pain descriptors for bones?
No.
Okay, all right. And what else? Could possibly deep. Deep, most likely dull and deep. Okay, dull and deep. So go back and review those.
For anterior drawer tests, you can be short sitting or prone. I'll just do short sitting. Alright, I'm going to stabilize the tibia and fibula with one hand and grasp the calcaneus with the other. And I think I'm just applying the anterior force. Yeah. And then just coming up. Positive sign would be anterior translation of the talus away from the ankle mortise.
And what does that indicate?
This would be anterior or ATFL sprain.
Because there's gonna be more laxity in it if it's sprained. So then you're gonna have a greater translation of the talus and calcaneus.
You can also do it.
So if you see your patient really acutely after the injury and they have a lot of swelling, okay, and you do this, recognize too, and there's a note about it in here, but you may or may not see a lot of translation because they've got so much swelling, it's taking up space, the swelling almost acts like a stabilizer just by taking up space, right? So as that swelling goes down, you may find that laxity seems to be a little bit more significant as their swelling comes down. So just keep that in mind. You might see a difference in finding their really acute versus after their swelling's gone down. So.
Quick question about swelling. You may want to write this down because you're gonna see this. You're gonna see this again. Does swelling increase range of motion or decrease range of motion?
Decrease.
All right. Does swelling inhibit muscle contraction or facilitate muscle contraction? Does swelling increase muscle force production or decrease muscle force production? All right. You're gonna see that on the exam. It's gonna be in a clinical. It's gonna be in a clinical application question. You're gonna have to extrapolate what we just went over. It's gonna be patient presents with increased circumferential measurements of the right ankle, right foot, such.
Are we gonna like?
Just to take it a step further, what if this is your patient, their ankle is swollen, and you're checking passive range of motion and tilt? How'd you feel? How would you describe it?
Now we're doing the Taylor tilt test. So we'll be laying kind of like on the side a little bit. Like this. I'm gonna place the foot in a neutral plantar flexion and dorsiflexion position, and I'm going to tilt the talus into an adducted position. Right. And I'm pushing it this way. Is that correct?
Yes, because you're assessing
Okay.
this Taylor tilt with inversion. So what ligament structure are you assessing?
The calcaneofibular ligament.
And it may also stress.
The ACFL?
Yeah.
You do. Perfect.
Yeah, do.
Good job.
We are looking to see if there's greater range of motion on the involved foot than the non-involved foot.
Yeah. So there's greater range of motion with inversion. So that means we have some laxity due to the spraining of the calcaneofibular ligament if the person's in neutral, foot is in neutral position. Okay. So good job.
Put this one kind of behind you. Now we're going this way. And this is for the deltoid ligaments.
Okay. And what are you looking for a positive test?
Still just greater range of motion on the involved foot than the non-involved.
Yeah. So greater range of motion with ankle eversion. All right. So now you also have to know the anatomical structures that are being assessed with these special tests. So when you're studying for your lab practical, you're studying for your written exam as well. But you're gonna see this on the written exams as well. So make sure that you know it. All right. So you may be asked about a special test, but in the form of knowing the anatomy that you are assessing with that special test. Does that make sense? So you can see a question in that form. You have to know that.
Are we doing the Thompson test?
Yeah.
This is a
Yeah.
test to assess the Achilles tendon. So I'm gonna have my patient in the prone position. So if you scoop, foot's supposed to be off the mat. So what you want to do is squeeze the gastroc soleus complex, and in doing this, the patient's foot is supposed to plantar flex. If there is no plantar flexion, then that is a positive indication of an Achilles tendon rupture. So she's good. I will now assess the other side. As you can see, good plantar flexion.
clinically, what if she does not plantar flex when you squeeze her gastrocsoleus complex? What if she doesn't plantar flex bilaterally?
Could be a nerve issue.
There you go, Emery. Could be a nerve issue. Now you can refer out for like some EMG testing.
Now we're gonna do the Feist line test. So I'm gonna have my patient sitting.
So I'm trying to make this line as straight as possible from here to here. There we go. So that's my line right there. Okay. So you want that line to be as straight as possible. So base
First,
tip of the medial malleolus. That's good. And what we're looking for,
navicular tuberosity.
navicular tuberosity.
Should be almost middle.
Let's see if I can get it. There we go, right there. I feel that little knot right there. I had to make sure I find it. Get it right there. All right. Now let's see what happens. Stand up. And it doesn't. Okay. So that'll be a negative test.
Don't for this test, we gotta perform it 2 different ways. We read it as first we should have the patient sitting to see if it falls. The navicular tuberosity is below the line while the subject is seated, then it's congenital pes planaris, but then after that we want them to stand if it's not congenital pes planaris, so we would have them standing. And then if it falls, it's due to functional pes planaris. So should we
Okay.
have it done,
So
be
you can
performed
do
that way?
So you do it that way, yes, you would do it that way. So in your case, you don't have neither. Your test is indicative, negative for both. So it's negative for congenital.
We're doing the windlass test.
So when I get her here, I'm coming, you said first MCP, but you extended the first MTP, metatarsophalangeal joint. So I'm gonna come right here. Her IP is gonna remain flexed. I'm gonna extend her at the first MTP, right? So I'm extending her. And so this is the windlass non-weight bearing test. So this is the done weight bearing portion, okay? So basically, when I extend her at the first MTP, I'm looking for a report of pain along the sole of the foot. So it could be anywhere along the sole of the foot towards the heel. So typically, if the person has plantar fasciitis, with us stressing the flexor hallucis longus muscle and tendon, typically that influences the plantar fascia as well, and it would likely generate pain. All right. Now she's gonna stand. This is the weight bearing portion. So you have the windlass non-weight bearing, and then the windlass weight bearing. All right. Now non-weight bearing may not reproduce symptoms, so therefore we're gonna see if weight bearing reproduces symptoms. All right. Or weight bearing, non-weight bearing may produce symptoms, while weight bearing produces worse symptoms. So go ahead and stand on both of these. Stand with both feet on this. Now with this one, you're gonna place your metatarsals heads at the edge. All right. Now, I'm not doing anything to her IP joint. I'm just allowing it to stay relaxed, which is gonna stay flexed. So I'm gonna stand her at the MTP. So, MTP. There we go. Gotta get up under this big toe. All right. They stand right there. And so now she remains flexed at the IP. And so again, I'm looking for a reproduction of symptoms anywhere along her plantar fascia and heel. And this is the weight bearing, the windlass weight bearing test. Does that make sense?
So asked you what structure you applying the stress to, what would you say?
It's the proximal wet. Mm-hmm. Good. So y'all gotta make sure y'all go back and know that. For practical purposes, you wanna do non-weight bearing and weight bearing. Mm-hmm. Cause those are components of the windlass test. So non-weight bearing and weight bearing. Okay, that's why I took time to go over them. All right. And so, and that's how it's clarified and done, right? Mm-hmm. So you got the non-weight bearing component and the weight bearing component. How many tests before?
On the table, the ball that extended. So I'm coming around here with the arms and squeezing here for 1 to 2 minutes. So there were my patients that have any pain, tingling, or numbness in their foot, toes, or ankle, and that would indicate interdigital neuroma or Ortho's neuroma. All right, same thing over here. Both sides were negative for Morton's neuroma, since my patient didn't have any numbness or tingling.
If he did have numbness and tingling, when would it likely be relieved?
At that release. All right, now we're going to the other side. I took this supine. I'm tapping over the medial aspect of the ankle where the posterior tibial nerve is most superficial. And again, asking for numbness or tingling. If he does have numbness or tingling, it could be indicative of potential tarsal tunnel syndrome. You have any numbness, tingling? Okay, you're good. I'll do the same thing over here. Are you experiencing any numbness, tingling? Okay, so both sides were negative.
So are you tapping anterior to the medial malleolus or posterior to the medial malleolus?
I believe you said posterior. Dorsal exposed lateral to the tendon. Like that word.
Either peripheral vascular disease or peripheral arterial disease, PVD/PA.
For actions or community posts.
Yes.
Gotcha. All right.
Person's likely gonna present with what they call intermittent claudication. So they're gonna present with pain, with walking, vascular type pain, with walking. If they present, likely have that condition going on. So you can do, you can refer back out to, we can do it, we just have to have the tools to do it. We can do an API that can work your index. So when you look at the compatible upper extremity and lower extremity pulses or blood pressure, and then you can calculate the API accordingly. But they have sheets that show you how to calculate the API. So we can do that if we have the tool and then refer out based on our score of what that we get.
I'm doing the pressure test. I took this supine. So with this finger that's extending, if it's good, just off the table, you can switch towards me just a little bit. All right, so I'm standing in this position, his ankle into maximum dorsiflexion to optimize joint congruency. Find the part set to the bottom of his heel. So, right, set. Or the other side, what I'm looking for on this side. It's pain at the site of the injury and indicate a fracture. So now we're doing the same thing on the other side. That's the dorsiflexion. have any pain?
Well, if there's no deformity, don't be hesitant to give a firm tap. Maybe use the heel of your hand. You want to translate.
You good?
You want to use your clinical judgment, and you might start easy, but if they tolerate easy, you might.
Both sides were negative for a fracture. Long bone compression test. I said it's supine, the leg, extending the foot on the table. Examining them at the end of the table, and I'm applying a compression to the long axis of the bone, the toe or metatarsal index. Okay, cool. We're doing the so. Before I get started, pain at the site of the injury is indicative of a fracture. Apply compression. Is there anything there? Okay. Apply compression. Is there anything there? All right, so both sides were negative for fractures.
Where would the fracture likely exist?
But
Where would the fracture likely exist? That's it, metatarsal. Whichever one that you exist.
thought you wanted some more.
Oh, no. With our component motions at the talocrural joint. All right. The first component motion that we're going to assess is the posterior glide of the talus. And so the posterior glide of the talus is a component motion required for talocrural dorsiflexion and weight-bearing pronation. Okay. And so the talus has to glide or slide posteriorly with active range of motion dorsiflexion. So that's a component motion necessary. So if I get a patient comes to me and my patient lacks ankle dorsiflexion, of course I'm going to assess the posterior glide of the talus on both sides. Okay. So I'm going to place my wedge accordingly. My wedge is going to block her distal tibia and fibula just above the joint line. My web space of my hand is going to be able to contact. So right here, I can localize the lateral malleolus and I can localize the medial malleolus. So I know that in between that lateral and medial malleolus is my talus. So I know my talus is right here where my thumbs are. So I'm gonna make sure the foot is in neutral. Everything is in good alignment. So neutral in between plantar flexion and dorsiflexion. So I'm stabilizing the distal tibia and fibula, and I can impart. So work through. I'm gonna bunch up the skin here. Work through and impart. I'm gonna ease up off of that. And I may get an assessment of her posterior glide of the talus on the tibia and fibula. I might assess that about 3 times so I can get a good feel for that. Okay, I'm gonna go assess the other side. Notice I use some towel on the wedge, so to help soften the wedge. The wedge is hard, so to try to make it tolerable and more comfortable to the patient. So make sure I got her in good alignment. Make sure she's not excessively internally or externally rotated. All right, I want to use my wedge effectively. So I want to block just above the joint line so I can localize her medial and lateral malleoli. Scoop back some for me. There we go, perfect. That's better. Good. Again, I'm stabilizing and my force is going from anterior to posterior. And again, I'm making sure I mobilize the talus. Did you feel that? So as I went posterior with this one, the initial glide I heard like a little clunking. It felt like a little clunking, but I no longer feel it. So sometimes that can be normal the first time. I assess it a few more times. Okay, so now I can give a clinical impression. I can give an assessment. So first I'm going to talk about the quality of the motion. So the quality of each motion was smooth, so nothing aberrant, nothing blocking or nothing stopping. So smooth quality motion. The next, the grade. For her bilaterally, if I compare the grade, comparing the non-involved, so I did the non-involved first, and hypothetically this is the involved. So in comparison to her non-involved, they were the same. She would get a grade 3 or normal. So both translated the same posteriorly, okay? And then for the infield, I would say it would be a posterior firm infield, normal firm infield, posterior posterior ligaments of the talocrural joint. Okay, so that's how I would verbalize that. Okay, and so the reason why I say the posterior aspect of the joint capsule or posterior ligaments, an aspect of the posterior ligaments, is because the restriction is going to be into the direction that I'm going into. Okay, because it's convex moving on concave. All right. So this is the posterior glide. So now we want to go to anterior glide. So the anterior glide of the talus on your tib field is going to be required for plantar flexion. So when we plantar flex, the talus has to glide anteriorly. So that's the component motion. The anterior glide is also required for weight-bearing supination. Okay, so make sure y'all pay attention to that on the slide, weight-bearing supination. Go ahead and turn on your stomach for me. Okay, good. So again, I want my wedge just above the joint line. So got her medial and lateral malleoli identified. And so this wedge is gonna be just above her medial malleoli. Because the lateral malleoli is a little bit longer, comes down a little bit further than her medial. So I'm gonna make sure this is just above her medial malleoli. All right, again, I stabilize. Now, you see the calcaneus, right? You see the calcaneus, her heel. I'm coming right on where the calcaneus ends so that I'm on the talus, or where it begins. So I'm on the talus and I'm applying my PA, posterior to anterior force, to the talus. And so my force is going straight down like this from posterior to anterior. You feel that? So each time I'm feeling a clunking sensation. I've tried it each time a clunking sensation occurs. Do you feel that, Devonna, each time? Every time. So every time there's a clunk, I'm gonna notate that. I'm gonna describe that in my documentation as a clunking sensation felt and also heard with the anterior glide of the talus on her left foot. All right.
What do you call that, a smooth motion?
All right, scoot over to your right for me. Yep, so I wouldn't classify it as smooth because I heard some clunking. And she felt it as well, so I confirmed it with her, and she said each time. And guess what? I felt it each time. So we only go off what we feel. We don't make up anything. We just document what we feel, you know. All right. Again, this wedge is just above the medial malleoli. So that's probably the best place to have it for the posterior glide as well. Just above the medial malleoli. I mean, right just above it so that it's not blocking the joint line. I'm gonna come here, again, stabilizing the distal tib field and also using the wedge to stabilize. My web space is on the talus, the posterior aspect of the talus. And now I'm gonna apply my anterior glide. And I'm also making sure her foot is maintaining in the loose pack position. about 10 degrees of plantar flexion. Now, right there, each time. So there's a clunking, there's a clunk with this one as well each time. So now, I gotta question myself. Is this normal for her? Because she's presented with a clunk going from posterior to anterior each time on both sides. And then when I did the anterior glide, she didn't have any clunking sensation besides the first time I did it, but it went away with the posterior glide of the talus. So my clinical judgment, I just still notate what I felt. All right, I felt a clunking sensation on this side as well because I'm describing the quality. Okay, so there's a clunking sensation during the posterior to anterior glide on her right side too. Now, as far as mobility, the mobility was symmetrical again. So there was no hyper or hyper notated in comparison to each one. Does that make sense? So I would say that as her normal, the amount of translation or glide that she had, those would be normal. And her infield would be anterior ligamentous tightening. So normal firm infields on both of those due to anterior ligamentous tightening. So this net technique is a technique that I assess and use for treatment frequently. So this technique, on the slide it says posterior glide of the talocrural joint. However, it produces an anterior glide, but I'm posteriorly mobilizing the tibia and fibula. As I posteriorly mobilize the tibia and fibula with the calcaneus stabilized, what's gonna happen relative to that is that the talus is gonna glide anteriorly, which is a component motion that's necessary for plantar flexion and also weight bearing rear foot supination. So the calcaneus is gonna be, in a sense, stabilized against with the wedge and also with use of the plant. All right, and I'm gonna come in and stabilize with my hand as well. My stabilizing hand is gonna be around her metatarsals. I'll come here like so. And now my mobilizing hand is above, probably about 5 to 7 inches above her medial and lateral malleolus. And I'm gonna impart a posterior force to the tibia and fibula. Now what's happening is what I'm getting is an anterior glide of the talus as I impart this force. Okay, so a posterior glide, a posterior force applied to the tibia and fibula as the talus glides anteriorly. Now, her quality of motion right here is very smooth. This is good. I like the way this feels. Okay, so nice and smooth. All right, let's see what the other side does. Let's see if the other side is nice and smooth like that one. Yeah, it's clunking. So this is why you gotta compare both sides. Something's going on. I felt it each time. Let's see. You still feel it? Mm-hmm. So I don't feel it as much, but you still feel it. So feel like it kind of worked its way out, but we did feel it the first few times. So quality of motion over here is not smooth. So we got a clunking sensation. It's not a smooth motion like this side. So with something going on, we don't know. I don't know. It's just information I have at this point. Okay. Her grade grade felt symmetrical. She felt normal. So one side did not feel more hyper or hypo than the other side. And then both of the infields felt like a normal, firm infield. So a normal form infield due to the anterior ligaments and anterior portion of the joint tightening. Why would I say the anterior portion? And the talus is actually gliding anteriorly. So I'm using terminology in reference to the direction that the talus is gliding. Okay. All right. So that's the posterior glide of the talocrural joint with the calcaneus stabilized, but in actuality, the talus is gliding anteriorly. Everybody got that?
Why didn't that change the posterior? Because I thought the other one, when you did the inferior, you was moving the talus, it was anterior, but now you're moving tibia and fibia posterior. So I thought
But I'm describing my infield in reference to the direction that the talus is moving. Yeah, because the talus is gliding or sliding relative to anteriorly relative to the posterior force on the tibia and fibula. Okay, because it says it's talocrural joint. So, but that's the title of that technique. Maybe it should have been titled anterior glide with the calcaneus stabilized and mobilizing the tibia and fibula. But I don't know. Maybe they updated it. I have to look at the updated book.
Okay, so Dr. Carter, with the hip, when we do an anterior glide, we move the pelvis, but the the femur head is moving anteriorly, but it's firm due to the posterior compartment. So wouldn't that be the same here?
So that wouldn't be firm due to the posterior compartment because we're going to describe it based on the direction that the femur is moving or gliding. So it'd be due to the anterior joint capsule and anterior ligaments of the hip joint. Because it's the direction that the femur is sliding in. But we're just producing that glide. We're producing that glide indirectly. You see, through other osseous structures. Also at the hip, you're moving the concave. You're moving the concave surface on the convex surface.
Right.
So if technically, textbook, so if we're moving the concave surface on the convex surface, then it would be the opposite. Yeah. If you go back to the hip, right, and if you're moving through the acetabulum,
right,
and you're mobilizing the ilium, moving the acetabulum, that's why I said if you're mobilizing it posteriorly, right, then we're moving concave on convex. That's why I say it's going to be anterior. But go by what's done. If I come here, right, I'm going to mobilize the distal tib field, which is concave. All right, which is concave, and we have our talus, in a sense, the convex. And so I'm mobilizing the distal tib field posteriorly. So I'm mobilizing concave on convex. So if I'm mobilizing concave on convex, then the ligament is tightening or joint capsule tightness, whatever you want to call it, is going to be from the opposite of the mobilization force. So it's going to be anteriorly. Now the talus is gliding anteriorly, but we referencing the joint surface that I'm mobilizing. I'll come to the hip. It's here like so. All right. I come here to the hip, right? So I'm going to do an anterior glide of the femoral head, but I'm going to create that anterior glide by mobilizing I'm gonna be mobilizing the ilium. So the acetabulum is where it's gonna be mobilized, right? So I come here, right here, and I provide my posterior force. So now, concave is being mobilized on convex. So if concave is being mobilized on convex, then by restriction, or what's gonna limit me from going further, are the surfaces anterior in the opposite direction. You see?
But if you did the other one where her leg was bent, you're pushing into the acetabulum, that would be posterior, because now the convex is like
There you go. There you go. Yes. There you go. Okay. All right. So when I did, so let's go back and recap. So now when I did the posterior glide like so, right? So now I'm stabilizing the portion that's concave, and I'm mobilizing the convexity on the concavity, the talus convexity on the concavity. So now when I'm doing that, now my limiting or restrictions are gonna be in the direction that I'm moving. They're gonna be posteriorly. You see? If I flip her over and then I do the anterior glide, then the limiting forces are gonna be into the direction that I'm moving, which are gonna be anteriorly. Because now my mobilizing surface has changed. Okay. So good. That's a good recap. Makes me reprocess it as well. So good job. So we're gonna go through the lateral glide and medial glide of the talus. So we're mobilizing the talus, all right? So the lateral glide of the talus on your tib field is necessary for talocrural plantar flexion and rear foot supination, weight bearing. Because when we supinate, the talus is gonna glide laterally, all right, with weight bearing. And then also necessary for plantar flexion. So, all right, how am I gonna orchestrate this, right?
So if we got the prompt that said plantar flexion and rear foot supination, we can do any of the last three that we just
So now, lateral glide, this is what I'm gonna do. Because I'm gonna use my thumb, the force is gonna be through my thumb, and my index finger is gonna help with that, but most of it is gonna be with my thumb. So what I'm gonna do is get her there we go. Kind of get her foot like just resting on my shoulder like so. Make sure it's maintained in a loose pack position. Now I come here and stabilize. Again, I got the wedge just above the medial malleoli so that I'm not blocking the joint line. And now I'm dropping off. If you can come here, like come here, Cajun, look. And so right here's her medial malleoli. I'm bringing my thumb about right here, just below the medial malleoli. And I know my thumb has captured the talus. And then I'm gonna bring my index finger right here like so. And so it has captured the lateral aspect of the talus as well. And so what am I gonna do? I'm gonna take my thumb and my force is going this way, lateral. So I'm mobilizing the talus laterally. So on this side so far, it's smooth. I don't feel anything blocking. I don't feel any clunking, grinding sensation as I mobilize her talus in a lateral direction. You see that? Okay, and I can feel her talus moving laterally. I can actually physically feel it moving laterally. All right, so on this side is left side. So left side, smooth, for so far good quality of motion. Nothing blocking, no abrupt motion. So abrupt is just like a sudden stop. So I didn't get that. So you all should know what you should be feeling for and assessing for when you assess accessory motion, and also when you assess passive range of motion as well. All right. Now I'm going to assess the right foot. Same thing. I'm going to just rest her forefoot on my shoulder right there. Let it rest on my shoulder. And again, I localize always her medial and lateral malleoli. I bring my thumb right here like so. I can drop off of that medial malleoli, drop down off of that. And I'm right here with my index finger, just medial to the lateral malleolus. But now I know I have her talus. So I got her talus where I can mobilize it. So it's smooth over here as well. So no clicking or clunking, nothing abruptly stopping me with mobilizing her talus laterally or gliding it laterally. Both of those felt good. Grade or normal. In this case, I'm still mobilizing convex on concave. So, but I'm doing a lateral glide. So in this case, it's still the restriction and limited factors are still gonna be into the direction that I'm moving. So those will be lateral structures. Those will be lateral structures that will play a role in limiting the motion or stopping it from moving excessively with a lateral glide. So those felt good. Did everybody capture how I was doing that? All right. The medial glide is a forced arm or force in the opposite direction. So the medial glide is going to be necessary for talocrural dorsiflexion and rear foot pronation and weight bearing. Has everybody got that? So the medial glide will be done the same way. So how would I do the medial glide? I'm just going to show you. Again, for these, I utilize my thumb. My thumb is what I heavily utilize to impart that glide. So on this side, I'm gonna do it's gonna be like a little flip flop. So her feet are gonna be resting right here. Now my thumb, instead of being on the medial aspect of the talus, now my thumb is gonna be on the lateral aspect of the talus. And I have her right here, supporting the loose pack position. And now my thumb, now my force is medial. Everybody see that? So now that's the medial glide. Medial and lateral glides feel good. Let me see how this one feels. So it makes me wonder about that one that's clunky. All right. And so again, medial glide, switching it up. Now my thumbs are gonna be on the lateral aspect of the talus. Coming here, stabilizing, and now my force is that way. Medial glide of the talus. Medial glide is required for what? There you go. So that'd be the medial glide. Because you think about those motions, that's what's happening. All right. Now, all right. So that's that one.
One hand that you feel comfortable with, use the other hand to make sure your thumb is being the one to apply force. And you do your due diligence.
So which glide are you doing now?
I'm doing a medial glide.
So
A lateral glide. I'm doing medial. Thank you.
So now she's doing a medial glide of the talus, right?
Yes.
And so she's showing that she's utilizing her thumb to basically impart the force. You know, forearm, thumb. So really it's your forearm, but your thumb is the guiding force as well. Now she's gonna do the lateral glide. Only thing she's gonna do is flip flop her hands, but it's still aligned so that her forearm and thumb is producing the force.
So you don't have to change over.
Yeah, so she really didn't have to change shoulders. She just flip-flop her hands, okay? And switch out the hands, okay? Now, I'm gonna be looking at this technique. Y'all make sure y'all practice this technique I'm gonna be looking for your forearm being in line of force and your thumb being the mobilizing force for your lateral and medial glides. Okay? I can see it better, and I'm gonna let you know right now, that's gonna be the way to do it, not to confuse me, myself, and Dr. McClure. Okay? Yes.
So, is there going to be an instance where this is the one that we have to, since there's 3 of them that we can use, since you're saying that we don't have to do this, right? If we're doing clarification and supination, we can do one of the other 2, correct?
So now, if I say, assess a component motion in the horizontal plane or frontal plane. If I say assess a component motion in the frontal plane that's required for ankle plantar flexion. Or if I say assess a component motion in a sagittal plane. So if it's in the sagittal plane, it's going to be your what? Anterior. But if I say frontal plane, yeah, it's going to be lateral medial. Mm-hmm.
You see that point at the bottom, it says normal ratio of movement and talus medial lateral is 1:1. So if it's not symmetrical in how much motion you're getting medial versus lateral, you typically walk, that's something maybe a little off too. Of course, then you're going to compare, but you're going to compare both sides. But so a
Let
lot
me
of
write
times
that
I
down.
would
So this is basically what she demonstrated. I can get her here, and I can assess the lateral glide. I can assess the lateral glide like so. And pardon my forearm, my line of force is this way, and I'm utilizing my forearm and thumb for the lateral glide. I can flip flop, and then I can go boom, boom. Now I can assess the medial glide of the talus. So I can do both of them. I can alternate and do both of them without moving the patient around and without moving myself around. You see? All right. And like Dr. McClure said, it could be beneficial to go boom, assess the medial, then come out, boom, and assess the lateral glide. Okay? So we know the lateral glide is occurring in the frontal plane, just like hip abduction, adduction. We know that the posterior anterior glides are occurring in the sagittal plane. So that's gonna cue you to which one, if I say assess component motion necessary that occurs in the frontal plane that's necessary for talocrural plantar flexion, rear foot supination, then you know, okay, Dr. Carter wants me to assess a lateral or medial glide because that is going to occur in the frontal plane. And if I say sagittal plane, then you know that I'm looking for you to do a posterior or anterior glide, vice versa, based on the case. Okay? Because now that ties in, we have to know the planes of motion, right? That's in our prerequisite courses. That's in human anatomy and physiology. That's high school too. Human anatomy and physiology, learning your planes of motion. So that goes way back to human anatomy in high school. So that's when you apply that knowledge. Planes of motion knowledge. All right. So that's a good question.
Now we are talking subtalar joint. Okay, so what is moving on what with this? What bone on what bone? What osteostructure on that? Cutaneous on the talus, on talus, okay? So we're gonna get our patient prone. We're gonna have their legs hanging off just a little bit, okay? And I wanna get her here so that I can stabilize. Now, I can be standing or sitting depending on what's best for my body mechanics, okay? So on the last technique, we did a medial and a lateral glide of the talus on the tibia and fibula, and we said it with a 1-to-1 ratio. Calcaneal arc glide is different, okay? We should see twice as much motion with the medial arc glide compared to the lateral arc glide. So it's a 2-to-1 ratio, medial arc glide to lateral arc glide, okay? And that's significant because we're working through this. I want to make sure my patient's comfortable. If I need to, I'll put a pillow under her waist, but she You okay, Devonna? You okay? All right. So calcaneus on the talus, right? So I can take, if I start with her left foot here, okay? I can take, or let's start with her right foot. Is that which one? The picture.
Yes, he's right.
Right? All right. We'll do the one in the picture first, and then I'll do the other one. All right. So I'm going to stabilize her talus, and I'm going to move her calcaneus on her talus. So if you can picture this, it's an arc motion. Okay, as opposed to a pure glide, it's kind of an arcing motion. All right, so I can come here if I'm going to assess medial arc glide. I'm going to reach around here and I'm going to stabilize the talus. I like to stabilize it like this and get my hand like this on the calcaneus. And now I can provide a medial arc glide. Now I think, and you may see some people may grab it like this. I feel like I do better if I get it like so. I feel like I've got a better grasp, stabilizing talus, reaching right up here under the crura, stabilize talus, and apply a medial arc glide. Now again, this is one where because of that ratio, I find it a lot of times useful to check one foot, or medial and lateral on one foot, and then go to the other foot. So I'm going to swap hands, just like Ebony showed us on the last technique. So I'm going to come around here, I'm going to stabilize talus. I'm going to come around here now with my left hand, forearm in line, and I can apply a lateral force. And you guys are going to be like, oh, yeah, this is different. It should feel different because it's a 2-to-1 ratio. There should be more motion medial, twice as much motion medial as there is lateral with this arc. Okay, it's a smooth motion. I don't feel any clunking. Okay. And that felt about 2-to-1, okay? Courtesy distraction thing. All right, so I'm gonna come in here and I'm gonna stabilize now talus with my right hand so that I can get my left hand here on the lateral surface of the calcaneus, and I can apply, again, a medial arc glide. A little clunk there. I only felt it once. Okay. And now I'm going to swap hands. And I'm going to feel a lateral arc glide. Okay. Both sides, the medial motion is more, a little clunk there too, than the lateral. If I had to say, I would say that the lateral arc glide of the right foot is slightly hypomobile compared to the left, okay? Because I would almost call it, it's just a little bit more restricted. There's a clunk there too. If I stabilize really good, a little clump there too. Okay, so I would say a grade 2 hypomobile lateral arc glide on the right compared to the grade 3 lateral arc glide on the left. Okay.
And based on Charlie, I'm getting Victoria to fact check. So based on Charlie, it appears that we're mobilizing the convexity of the calcaneus on the concavity of the talus. That's what it looks like with Charlie. So if you come and look, you see that convexity on concavity on the lateral aspect and also medial aspect. Okay. So we're gonna fact check what that. Yeah. And so what it said. So normal infield, the infield is firm because of tension in the lateral joint capsule. So the anterior and posterior talofibular ligaments and the calcaneofibular ligament, so those are lateral structures, and the lateral, posterior, anterior, and interosseous of the talocalcaneal ligaments. I fact check maps up with the concave, convex rule, and does. Okay, so you want to know that as well. I looked at Charlie and I looked at the articulation and I looked at the convexity of the calcaneus, and I looked at it moving on the concavity of the talus. Okay, and that convex moving on concavity rule is going to determine our infield rule. Okay.
So, calcaneal rocking, or rock of the subtalar joint. Okay, so again, we've got a calcaneus. So essentially, we're moving the calcaneus on the talus. Okay, so let's just talk about that step one, right? So I'm going to stabilize the talus. Okay, I'm going to get standing. I'm going to put my hand here, and then with wrist extension, okay, I can, do you see how I can make the calcaneus rock? Okay, in this motion. Can you see that? Okay, and then if with wrist flexion, I can make the calcaneus rock that direction. Okay, so that's what the wrist flexion extension is talking about up here. Okay, so with wrist extension, is if I stabilize talus and I extend my wrist, it's gonna be a component motion necessary for dorsiflexion. Okay, this is gonna help improve dorsiflexion. With wrist flexion, the calcaneus is going to rock in that direction, and that is going to be the component motion for plantar flexion. Okay.
So we're rocking the calcaneus on the talus.
Okay, so that here, stabilizing talus, cupping the calcaneus with my hand, and then I'm going to extend and flex my wrist to create calcaneal rocking. Okay? They felt fairly symmetrical to me, both sides, and smooth. I didn't feel any clunking. I would call her a grade 3 normal in all of those motions for calcaneal rocking.
Okay.
Wrist flexion is going to be for plantar flexion. Okay, you can see stabilized talus. Can you see? I'm trying to exaggerate. Can you see my wrist flexing? Okay, and it's taking the calcaneus this direction versus when I extend, it's rocking the calcaneus in this direction, which is component motion for dorsiflexion.
For distraction of the talus, right? So we already know joint plate motions help with what? All classical motions. So it's good to know how to be able to do them. All right. So now I come here. I got two options that I can utilize for distraction of the talus from the till field. So that's what I want to focus on right now. So the first technique is the one that's going to be at the top. I'm going to stabilize the till field. I'm going to come in with my hypothenor eminence and my fifth metatarsal and fifth digit, and come around the talus like so. My thumb is coming around the lateral aspects of the forefoot. And so what I'm going to do is impart a distraction force like so. So I'm using forearm muscles in my hand. It's like my, almost like I'm going in doing like a little scooping technique to create a distraction like so. Okay, so this is what I'm doing right here, and I'm doing this to the talus. Okay, so I'm trying to impart that force on the talus. Can you feel that? So yeah, I may not.
Definitely one you want to bunch skin on.
Yeah. So yeah, so I can bunch the skin like so, and then that way I distract so that I'm not moving a bunch of skin. All right. For time's sake, I'm not gonna go through comparing both sides like I started at the beginning with everything else, but y'all know the concept. Y'all know the idea behind comparing both sides and giving you clinical impressions with both sides. The other way I can do this, I can come in and grasp interlock my fingers and come like so, and make sure that my 5th digit captures the talus, okay? And now I can impart my force with my forearms pulling back, almost like I'm trying to do scapular retraction. So when I'm doing it like this, I'm trying to retract my shoulder blades, my scapula, when I'm doing this, because my elbows are going back. And I'm, in a sense, scooping as well, simultaneously with that. So that's distraction of the talocrural joint. Again, the forearms exert a caudal force and lean it back into the clinician's body weight. And so basically that's what I was doing, like so. I feel like I can get a greater distraction using the bottom technique versus the top technique. The only thing is with the top one, I'm stabilizing the tib field, which could make a difference as well. I'll come over here and do the same thing. Now, Devon, which one did you feel like gave a greater distraction?
I felt the quirk in that one, but I feel like it was a better distraction than the two.
Okay, so she feels a better distraction with using the forearms and leaning back into it. This is one, I want to go through this one because I use this one extensively in the clinic, and it's a good one to know because you can see this one on the National Physical Therapy exam. Scoot back for me just a little bit. All right. So this one right here is superior motion of the fibula. It's a joint play motion that's necessary for all motions at the knee. So if your patient lacks range of motion at the knee joint, this could be a good one to add to it, especially if your patients had a total knee joint replacement. If they had a total knee joint replacement, it could be that they're lacking component motions or joint play motions necessary at the proximal tib field articulation. So this is a component motion for ankle dorsiflexion. So this superior motion of the fibula. So I come in like so, and my thenar and hypothenar eminence is going to be on the lateral aspect of the calcaneus, and I can actually come up here and palpate as my line of force is superior through my forearm and my thenar and hypothenar eminences. So her fibula is gliding or moving superiorly, which is what it has to do for ankle dorsiflexion. So if you palpate your tibia, fibula, the proximal aspect of your fibula, and you dorsiflex, you're gonna feel it move superiorly. It's gonna move superiorly. Gonna move sypholic. Okay. So there's a joint play at the knee and component motion for ankle dorsiflexion.
It's also one I see a lot, it's problematic in patients who have lateral ankle sprains. All that tissue attaches to the fibula. As they come down like that, sometimes that fibula will even ride a little inferior. Needs a little help to move back posterior to superior. So if your patient's lacking dorsiflexion after a lateral ankle sprain, make sure you're checking that.
And this is a joint play motion that's good for those who have high ankle sprains. So someone talked about high ankle sprains today, being a syndesmosis that connects the tibia and fibula. So if someone has a high ankle sprain, this is a good assessment and treatment because you may notice a difference over time. So this assessment, they may be painful, have like a painful infield with this assessment. And so you just notate that on the assessment and notate the quality of that infield and quality of the motion, and you may come back and reassess it every 6 visits or so. But what we do with this one, we place the wedge. And I'm gonna I'm gonna remove the pillow. All right, scoot back for me some more. All right, good. I wanna take this wedge, and now this can be an uncomfortable technique. So this wedge is actually gonna block and be along her lateral malleolus. So it's gonna hook up underneath her lateral malleolus, all right? And so what I'm gonna do, I'm gonna come in, kind of try to help stabilize this so that it doesn't slip off. And now I'm gonna impart I'm gonna be on the medial aspect of her tibia, and I'm gonna impart a posterior force through the distal tibia. There we go. Now, I have this hooked on there. So you see how her lateral malleolus is on this wedge, and it's not moving, it's not coming off of it. All right, so I'm assessing her syndesmosis, her tib field syndesmosis. All right, this is joint plate necessary for all classical movement of the talocrural joint. Set that aside. Now to see how it looks from over here. Screw back for me just a little bit. There we go. Stabilize. Oops, it came off of there. Let me get it to come on. There we go. So you would assess those and give you clinical impression. All right. I'm like, don't neglect practicing. Don't wait till the last minute, because everything I do is comprehensive. Everything is comprehensive. All right. So you gotta be on your P's and Q's with using your time wisely. Because yes, although you're getting all this week, yes, you will be prepared, have to know it for the final practical. So that means if you've been studying the remainder of the content all along, then you don't feel as stressed when it comes to picking up the new content that you gotta know. That's PT school. And it's just the nature of it, all right? So you gotta do it. It's National Physical Therapy Exam content. Now, we're gonna move on to some other joints. So the next joint that we're gonna move on to is the MTP joint, all right, the holics. So we're gonna start off with a joint play motion that's easy. The joint play motion is distraction. Now, this is what we have to know. And I don't show it that much in this picture, so I got them in neutral. But what I want to do is, what I want to do for the loose pack position of the MTP. Who can guess? The loose pack position for the MTP joint is slight height extension.
Oh.
For the first one. For the first one. For the first one. For the holics. So for the holics. So Team Tech, you didn't have many, but the few that you had, y'all got it. All right. So now I'm gonna put her in slight extension at the first MTP, and then my force is gonna be a distraction force in line with my forearm, like so. Okay. Okay. Then, of course, I can assess both sides if I want to, and then provide my clinical impression, slight extension, and then distract. Notice how I'm using a wedge. I'm using a wedge to stabilize the first metatarsal. So I'm stabilizing with my hand, stabilizing that against the wedge so that it doesn't move, putting the MTP joint in extension, slight extension, anywhere between 0 to 20 degrees of extension, and then applying my distraction force. All right. Again, a joint play motion necessary for all classical motions at the first MTP joint. Okay. So that's an exception with the first MTP joint with the loose pack position. All right, being in slight extension. All right. So now I'm going to do a plantar glide. Okay. So all right. So plantar glide of the first MTP joint is component motion required for MTP plantar flexion, or we're going to say flexion of the first MTP. Now, when we mobilize the proximal phalanx on the base of the first metatarsal, we're mobilizing concave on convex. So since we're mobilizing concave on convex, that glide or slide is going to be in the same direction. So we're assessing the component motion that's occurring in the same direction of that motion. Does that make sense? All right. So I'm going to place her into extension, and now what I'm going to do is bunch up the skin, slightly unload the joint. So I'm going to slightly distract the joint, and then apply the palmar glide. Not palmar, plantar. I'm at the foot now, so plantar. All right. Again, I'm notating the quality of motion. That was smooth. No abrupt motion, nothing stopping me. No clicking, clunking, no grinding. That was good for quality. All right. I'm gonna come over here, same thing, stabilizing. Now, with my stabilization, that can contribute to bunching up skin as well. You see this? So I'm bunching up skin with my stabilization hand, bunching up skin with my mobilization hand, slightly distracting, and now apply my plantar glide. Those feel good. So good, symmetrical, great, symmetrical, smooth, grade 3 normal. For since I'm moving concave on convex, then we know my restriction, or what's gonna restrict me from moving even further, is the direction that I'm moving away from, okay? And so that would be her dorsal aspect. So dorsal joint capsule. All right. So that's that one. So dorsal glide is reverse. Okay. So dorsal glide is going to be required for MTP extension. So it says, yeah. So it just said for the reverse. So that's BPT extension. So if I come right here, right, like so, I can come right here, bunch up the skin, place her in slight extension, and then the glide would be towards me. So I'm gonna make this where it's in line with my forearm, and I distract some, and then glide towards me. Okay, so that would be the dorsal glide. So the dorsal glide would actually be used to, it's a component motion that's necessary for first MTP extension. Everybody got that? Component motion necessary for first MTP extension with the dorsal glide. Plantar glide is necessary for what? So again, so with the dorsal glide, and notice and Devonna can tell you, my force is on the proximal phalanges or phalanx, on the proximal phalanx, just below the joint line. Okay, just below the joint line. And I'm mobilizing her, assessing her component motion in the dorsal direction. Okay, all right. Trying to see, is there anything else I want to add to that? That's very important. So now you got to know when to apply, when to assess this. So someone has limitations with toe off, right? Toe off, then you may want to assess MTP extension, because that's what the component motion required for that, because that's required for toe off, right? All right. So medial glide of the MTP joint. So we still at the hallux, right? All right. So the medial glide for the first and second MTP component motion of the first and second MTP abduction, and fourth and fifth MTP adduction. So let's come here. All right. So if I come here like so, now, so this anatomically, this is the medial aspect of the foot, anatomically. Anatomically, towards the fifth digit, or the fifth digit is the lateral aspect of the foot. So now I want to assess the component motion that's necessary for first MTP abduction. All right. So in this case, abduction of the first MTP is moving away from the midline. So we're gonna say the midline is, for reference of the midline, that's her third phalanx, third metatarsal. So she's going away from the midline, she's going this way, she's going medial. Okay, does everyone capture that? So she's going medial. So what am I gonna have to do to assess the component motion required for abduction, moving away from the midline? So there's gonna be a medial. I'm gonna put her again into extension. I can't forget that. Put her to extension at the MTP, bunch up the skin. So notice I'm bunching up the skin, and now I'm applying a medial glide. All right. I'm assessing the medial glide as well. So now, why in the world would my mobilizing force be medial? That's the question. What rule is dictating that? Yeah, so concave convex rule is dictating that, right? Because I'm moving concave on convex. So now my glide is in the same direction of the movement, which is abduction, which is away from the midline. All right. Then I can turn around, assess the other side. Same thing. Bunch up the skin, put her into slight extension, and then assess the medial glide. She has good medial glides. Both of those are good and smooth. Both of them are normal. I would say normal. And then what would be my infield? What do you say?
Would it be the lateral capsule?
There you go. Because it's the one I'm moving away from, since it's concave on convex. Good job. All right. So let's see. And then, so for adduction, so if I do the fourth and fifth, all right. If I do the fourth and fifth, and I move medial. So if I come back here, I just want you to visualize this. If I come back here for the first and second, relative to the third digit, that would be abduction with medial. But for the fourth and fifth, if I do medial, it's gonna be component motions necessary for adduction of these, because now it's going toward the midline in reference to the third metatarsal. Everybody got that? So I will come here. Now with these, for the loose pack position, where do I put the second through fifth? Slight flexion. So now I'm gonna put it in slight flexion, and now apply my medial force. Now if I was sitting, I can get a better line of force through my forearm. So this one may be one that's better for me to do in sitting, right? So I come in sitting position. Now, oh yeah, now I'm working. Now I'm working like a PT. There we go. Slight flexion. Then can bunch up the skin and apply my medial glide, which is necessary for metatarsophalangeal joint adduction at the fourth digit. All right, same thing here. Light flexion, bunching up the skin, and applying a medial glide. Component motion necessary for a 5th digit MTP adduction.
We'll do a grade 1 distraction on that as well.
Oh, you can. Yeah, you surely can. You can always unload the joint. It's best to unload it, grade 1 distraction, and then do it. Yeah. So good job. Good observation. So this is mobilization. Again, we start with assessment. We can transition to treatment. This is joint play motion necessary for functional gait, dorsal and plantar movements. So we know that if we are supinated at the rear foot, what are we gonna do to compensate at the forefoot? Pronate. But in order to do that, the metatarsal heads have to move in a plantar direction. All right. So that's going to be required. That's a requirement. That'll be a necessity for the plantar, for the metatarsal heads to be able to move in a plantar direction. So if we're pronated at the rear foot, our forefoot is going to compensate by doing what? Supination. And so when in regards to supination, with forefoot supination, likely our 1st through 3rd metatarsal heads have to be able to move dorsally. All right. But either way it goes, for a normal gait, our forefoot, the metatarsals have to be able to move dorsally, and they have to be able to move plantarly. All right. And so that's something we may want to assess to see if the patient may have a restriction with those. But I'm going to start, and typically we assess the 2nd through 5th metatarsals with this technique. So I'm going to come in and I'm going to start with assessment of the 2nd metatarsal head. So I'm going to come in like so, and you can see my index finger on the superior aspect or the dorsal aspect of the 1st metatarsal, and my thumb is on the plantar aspect of the 1st metatarsal. So I'm stabilizing the 1st metatarsal. All right. Now I can come in with my index finger over the dorsal aspect of the 2nd metatarsal and my thumb over the plantar aspect of the 2nd metatarsal. And I can move so I have the 1st one stabilized, and I can mobilize that 2nd one plantar in the plantar direction, and I can also mobilize it in a dorsal direction. So mobilizing metatarsal head plantar direction and also in the dorsal direction. All right. I can move over, stabilize 1st and 2nd metatarsals while I now mobilize the 3rd one in a plantar direction and mobilizing the 3rd one in a dorsal direction. So I can go back and forth, plantarly, dorsally. And I'm not blocking the 3rd metatarsal from moving, but I am blocking the 2nd and 1st metatarsal. So I'm mobilizing the metatarsal heads and the dorsal and plantar movements. Everybody see that? Then I'm gonna come over and capture. I'm using all of my thumb and index finger, majority of it, and I'm capturing the 1st through 3rd metatarsals, and I'm stabilizing the 1st through 3rd. And guess what I'm gonna mobilize next? Which one? Which one? The 4th one. Okay. So now I'm mobilizing the 4th one. And again, I'm not just mobilizing, I'm assessing what I feel as well, because I'm going to compare both sides. So plantarly, dorsally, plantarly, dorsally. Now, for forefoot, I'm going to ask you a clinical question. So if I mobilize the dorsal, mobilize the fourth metatarsal dorsally, what is that helping to improve? What motion of the forefoot would require the fourth and or fifth to move dorsally? Plantarly. Yeah, inversion. So inversion of the forefoot, or you could say supination of the forefoot. So with supination of the forefoot, the fourth and fifth will have to move in a plantar direction. You see? You gotta visualize this in your head. Now, for, say for forefoot pronation, all right? Forefoot eversion. Which direction should the fourth and fifth metatarsal heads move in? Dorsal direction. So dorsal direction. And you apply that same concept to the first and second metatarsals. The third is typically referred to as a reference point, is our mid metatarsal, right? And so we typically refer to that, that's our reference for abduction, adduction of your phalanges. It could be our reference for maybe inversion, eversion per se. All right, now going back, I'm taking my time going through this. So if I go stabilize the first and I move the second one and a plantar aspect, what would that be required for? Forefoot what? Who said it? Forefoot pronation. So the second metatarsal, in order for forefoot pronation to occur, the second metatarsal have to move in a plantar direction. Does that make sense? Which direction must the metatarsal head be able to move into for forefoot supination?
Which one?
The second one.
For what?
Supination. Say again? Dorsal. What about forefoot pronation? Second metatarsal head. Plantar. Yeah. So you need to make those associations, okay? And know what's going on with the metatarsal heads functionally at the forefoot. That's important, okay? Because this is something we need to be assessing with our patients with foot ankle problems. All right? Orthokinematics, biomechanics, looking for muscle imbalances, looking at footwear, looking at proximal strength, proximal range of motion, a whole lot of things you have to tie together and put the pieces of the puzzle together to improve one's movement and quality of life. Why do you say B? That's what you gotta know. Because what makes our therapy skill is knowing the why behind it. So it's not skill therapy if we don't know why we're doing it.
The rear foot, when you pronate, the first metatarsal has to go back dorsal. That's why it makes you choke.
So repeat that again.
At the rear foot, when you pronate, the first metatarsal comes.
Okay. So what Tavian is saying, you're thinking about your rear foot and forefoot relationship, especially during the mid stance or gait, or going into loader response, the compensatory strategy and the relationship between rear foot and forefoot. So we know the rear foot is pronated, all right? And we say we're in the mid stance or gait. What should happen accordingly is that our forefoot should supinate, right? And so which of these movements have to occur with forefoot supination? So it would be B. B has to occur with 4-foot supination. So the first metatarsal will have to be able to move dorsally. Now let's rule out if the first metatarsal is making a plantar movement, what is happening? The 4-foot is doing what? Likely. It's likely pronating. So this will be with 4-foot pronation. Now, fifth metatarsal dorsal movement. What's that gonna occur with? It's likely gonna occur with 4-foot pronation, because the 4th and 5th are gonna move dorsally, while the 1st, 2nd are gonna move in a plantar direction. Does everybody see that? Can you visualize that? So this is how you gotta be thinking on the test in your National Physical Therapy exam. You gotta think in a logical manner. And so we already said 4th metatarsal dorsal movement, that's gonna likely occur with 4-foot pronation. So the 4th and 5th are gonna move dorsally, while the 2nd and 1st are gonna move in a plantar direction, right? If the 4-foot goes into pronation. So this requires visualization as well. So this is the one with 4-foot. Supination. Which is what should occur with real foot pronation. So now this is part of teaching and learning.